Good afternoon or morning, depending on where you are. Welcome to Fibromyalgia Associations Canada's presentation. I'm Trudy Flynn, Chair of the Board of Directors of Fibromyalgia Association Canada, or what we call FAC. I'm going to keep my comments brief so we can get right to the presentation. Thank you for joining us today. If you are not a member of FAC, you can join at the link that I will be adding to the chat. Just hold on 1 second here. Or Mario, if you wouldn't mind adding that. FAC is committed to growing our membership for our advocacy work because there is power in numbers and together we are stronger. So before we get started, I'd like to cover a few housekeeping items. If you have any technical issues, please email Mario at webmaster@fibrocanada.ca or tag Mario in the chat. Mario is the Vice Chair of FAC, our webmaster, and he's also the Chair of the Education Committee. If you have any questions for Cecilia, please put them in the chat and we will get to them in the question and answer segment of the presentation. We have closed captioning enabled. This presentation is being recorded for those who could not attend, and it will be on our YouTube channel. All participants will be muted, and we ask that you turn off your video so only the presenter will be in the video. Okay, so let's get started. I would like to start by saying that although people attending may be spread across Canada, I am located in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which the Mi'kmaq first signed with the British Crown in 1726. The treaties did not deal with the surrender of lands and resources, but in fact recognized Mi'kmaq title and established the rules for what was to be an ongoing relationship between nations. In Nova Scotia, we are all treaty people. As part of this acknowledgement, I also recognize the histories, contributions, and legacies of the African Nova Scotian people who have been here for over 400 years. I recognize that without action, an acknowledgement is empty. An acknowledgement marks the beginning of the work ahead of us, not the end, in FAC's journey towards reconciliation. So I would like to welcome Cecilia Oscarson, and FAC is so glad to have you with us today, Cecilia. Cecilia is a licensed clinical psychologist who graduated from Lund University in 2010. She has been practicing for 14 years and is passionate and experienced in working with people going through difficulties in diverse areas, which include the following: long-term pain, like people with fibromyalgia, attachment trauma, stress, burnout, anxiety, depression, acquired brain injury, addiction, alcohol use, anger management, interpersonal relationship issues, and sexual abuse. Cecilia completed a 3-year core training program in intensive short-term dynamic psychotherapy in 2014 and interned at the Center for Emotions and Health in Halifax in 2013. Cecilia also obtained training and experience in cultural psychiatry and support in matters concerning the health in the 2SLGBTQ1A+ community. She employs a variety of treatment approaches to address the specific needs of each individual. She enjoys meeting people from varying backgrounds and providing support for better health. Cecilia is particularly excited to be working with people with fibromyalgia. Cecilia is physically located in Toronto, but works out of One-to-One Wellness in Halifax. Cecilia is licensed to practice psychology in both Ontario and Nova Scotia. If you would like to contact Cecilia after the presentation, I will put the link in the chat. Now to turn it over to Cecilia.
Thank you for that presentation, Trudy. And thank you for this opportunity to share some of the knowledge that I've accumulated in my work life to people who are affected by fibromyalgia.
So I will disappear, Cecilia, and I'll let you take over with your slides.
Then I will start screen sharing here. Thank you. I have the screen here that's covering where I start the presentation, so I'm just trying to figure that one out. Nope.
I could see your first page.
Oh, was it covering the whole screen as
No,
well? No.
no.
That's the
But it looks
part.
like maybe you're not in presenter mode, because I could also see all your slides.
Yes, that was the thing. I was trying to get the presenter mode going there. So I'll just exit full screen there and see if I can get it back again. Down there a little bit and there we go. So hopefully everyone can see the screen there. And
that looks perfect.
yes, I'm just trying to hide the slides there on the left so that I can see everything on my screen as well. I'm not sure how to do that, so I might just start and see. So the title of my presentation is Using Psychology to Transform Our Relationship to Pain. And the undertitle is Supporting Your Nervous System in Regulating Long-Term Pain and also Treating Trauma Related to Experiencing Long-Term Pain. In today's presentation, we will be looking at a few different topics. We'll start by understanding the role of pain in the nervous system to have that as a foundation. We'll also be looking at trauma-informed psychologist's role and opportunity in treating and managing long-term pain. We'll be looking at how trauma happens, what can cause it, and then also as an effect of that, what's needed in order to treat it. We'll be looking at some common psychological reactions to receiving a diagnosis, to normalize some of the reactions that a lot of people have when being diagnosed. We'll also be looking at a term called medical trauma, looking at how the interactions with healthcare and also symptoms are sometimes creating a traumatic reaction. And in order to also find a way to put this into real change and action, I will have some slides towards the end with some ideas for how to find support online and in your local community. So first, Shirley mentioned a presentation about myself. I've also added a few things here just so you know who you are listening to today. My name is Cecilia Oscarson. I'm from Sweden, in case there's an accent that you can detect. I moved to Canada a few years ago, and I am a registered clinical psychologist with a master's degree. I'm registered to practice in Nova Scotia and Ontario. And like Trudy mentioned, I graduated 14 years ago in Sweden. And my main treatment method that I use when I work with psychotherapy with clients is ISTGP. And another relevant part of my background, I've worked in many different areas, but I worked for 2 years at a long-term pain and burnout clinic in Stockholm. And that's where some of the knowledge that I'll be sharing today comes from. I'm currently working fully online together with a physiotherapist clinic, like Trudy mentioned, called One-to-One Wellness, specializing in long-term pain in Nova Scotia. So let's start from the beginning with this question: what is pain? And then also, why is pain? How come we have the ability to feel pain? And depending on how much information you've accessed through your communities and your healthcare provider so far, this might be familiar information for you. And for some people, it might be new. So it's in order to have a shared starting point for us all. How come we can feel pain? Basically, it is one of the ways that our brains tries to keep us safe. Without the ability to feel pain, we risk running into accidents and harming ourselves in different ways that throughout evolution, nature has deemed was not very effective. So if we can feel pain from putting our hand on a hot stove plate, then that is something that will keep us from doing that again. So that is the kind of foundation. So in that light, we can see and understand pain as a way that our bodies are trying to signal, send the alarm signal and signal that maybe there is danger, maybe there is injury. And that can often be a fairly straightforward communication when dealing with short-term pain. But as we'll discover throughout this presentation, when long-term pain happens, a few different other mechanisms start kicking in that makes that link between an injury and a symptom of pain less direct. And often not having any injury at all can also be something that we still have pain from. Pain operates in ways in our brain and in parts of our brain and in ways in the nervous system that don't require conscious thought. And that's also part of why it's been so advantageous evolutionary for us to be able to feel pain, because it goes from part of our body up to our brain straight away. And if you're interested in some more detail on that, there is a wonderful physiotherapist in Australia called Lorimer Mosley, who has some really interesting YouTube videos to look into. There are websites and so on, but I really recommend the YouTube videos. So we're starting to see pain in this light where its purpose is to try and keep us safe and to help us survive when it's working as intended. And this also leads us to be able to look at pain as a stress response. There's something that has happened that needs our attention. So the pain comes along and it makes it possible for us to start to pay attention, potentially about something that is stressful going on in our body. And then in long-term pain, something else starts to happen when this stress response and signals about pay attention to this, maybe this is injury, maybe this is something you need to notice, is going on for a very, very long time in the nervous system. It's almost giving, making the, not overheat as in that there's actually heat, but that the nerve endings get to send so many signals of this particular kind that they get easier and easier, like more and more easily triggered. And as a result of that, we might also struggle to be able to pay attention to other parts of the body that are not currently in pain. Places in the body that might feel calm or okay or neutral because of it pain's strong survival value. The pain signal gets more priority in the brain than the signals from maybe our tip of the nose or our earlobes that are not currently hurting. That signal tends to go into the background, which is something that we can use for treatment as well in ways to try and regulate the pain. The other big topic for my presentation, and that I'm hoping to link together with pain, is trauma. And we'll start with the same kind of starting point for this word as well. What is trauma and why is trauma? And it's a very similar function. It is a way that our brain tries to keep us safe. And there are many different definitions of trauma. The one I like to use that I find makes most sense in the work that I do is a very broad definition, a very wide definition. Anything that we've been through where choice was removed has the capacity or has the possibility of creating a stress response in the body. And then that starts to move like the definitions away from, it's not only natural disasters, not only like direct abuse, but it's also many everyday events where we have very little agency that can trigger a trauma response in our nervous systems. So any situation, whether it's housing insecurity, financial stress, stress in the workplace, can, depending on the impact that it's having on us, the symbolism it's taking on, or the real risks that are involved, has the capacity to create a trauma response in our bodies. One way that that can happen, for example, is if the demands on me in a certain situation is higher than the resources that I have available, whether or not those resources be financial or energy-wise, skills, and so on. So one way that trauma can happen then, if we use this definition, is having pain for a long time can create trauma, because we might be grieving the loss of a function that we used to have, an ability to go for long walks in the forest or something else, play with grandchildren and so on. It might mean that we have a lot of fears and thoughts about the future, what might happen because of this condition that I'm having. And because trauma is something that happens and is signaled in the nervous system, which is both our brains and all the nerves that go out into the body, it's the same system where pain signals travel. So what often ends up happening for people who experience pain for a long time is that stress and trauma can start to show up together or impact each other, and sometimes contribute to increasing each other, to kind of feed off of each other, which of course is very stressful. And then the other side of it is that we can use that mechanism reversed to try and help treat both the pain and the stress response, the trauma. So many of you might have experienced psychological stress at some point in your life, whether it be anxiety, depression, addiction, other symptoms that can show up. And it's not often that we talk about it in Western culture as something that lives in the body, but if starting to look into it from a mind-body perspective, it can often be a thing we can discover, that anxiety, depression, like it can feel like a heaviness, it can feel like tension, it can feel like a temperature shift, it can be many things that lets us know we're feeling unwell, and it's all happening in the arena of the body. So that is where psychological stress lives. It's not just this part of the body, it's also the rest below the neck. And the ways in which trauma treatment can help, and I'll get into this a little bit more later on, and some ideas of where to find resources around trauma treatment, is that when pain happens, when trauma happens, when stress happens, we get a lot of signals back from our body that we don't feel safe, that it's not okay right now the way things are, there's something that is off, or there's something that is dangerous. And regardless of which type of trauma treatment you potentially enter into or learn about, they are all centered around this concept of trying to recreate a sense of safety in the body while processing emotions, connecting to painful memories or different things that might be showing up. So a lot of the ways in which we can help in this area is by recreating a sense of safety. One big event for many people in their journey with long-term pain is the moment where they receive a diagnosis, or in other ways learn about their condition, especially if it is a long-term one or one that will never go away. It can have a big impact on one's life. And not everyone is going to react with trauma to it, but some people do, and depending on the relationship to your professional or the impact it's having on your life, it's going to take on either more or less weight and impact. So labeling receiving a diagnosis as a potential trauma is something that can allow us to treat it if there is trauma that has happened for an individual. One of the aspects of working with diagnosis-related trauma is looking at one particular feeling, grief. It might be one that we don't have a lot of experience with, or one that we really don't like because it is often a painful feeling. So we're now not only having physical pain, but also emotional pain. And it can often be hard to have resources or support enough to connect to that feeling and figure out, how do I process this? Who do I need support from? How do I go about this? Another big feeling that a lot of people feel is anger. And that is a feeling that often has a bad rep in Western culture as well. It's often one that we've been taught to suppress, or been told that it's not a good feeling to have. If you're a good person, you shouldn't be angry at things and so on. So many of us have different ways of dealing with anger that makes it less direct. We're not in contact with it as much, perhaps, as we might have been when we were born, or when we were younger. So normalizing anger as a part of a grieving process, or as part of healing a trauma, can also be a really important part. Normalizing it, and also knowing that often we've been taught to turn it inside instead of feeling it in the body or expressing it in a healthy way. And for many people, that can turn into other types of symptoms instead, like depression, anxiety, shame, self-attack, and so on. And if anger turned inward has a lot of a shaming effect, or we've been shamed by others who don't understand what we're going through, it can lead to mental health struggles of different kinds, like addiction, self-harm, isolation, suicidal thoughts. So it can be good to know both that there are supports in various provinces. I'm sure have different contact numbers. The 988 number listed here is the emergency phone number for Nova Scotia. If you have any mental health related concerns or a crisis, you can always call that 24/7. And if you're interested in understanding more about shame, which is a very social emotion and one that has a lot to do with evolution and how we've evolved into being social creatures, Brené Brown is a social worker, researcher who has gained a lot of fame in the last few years, which is a personal favorite that I can really recommend if you want to watch her YouTube videos or read her books. Another word that often people have come in contact with is acceptance. And most of the time, the people that I've met have had a lot of negative experiences often around this word. They've been told to move on or suppress their emotions, essentially, and not be as upset as they genuinely are about the life-changing event that's taking place in their life. So I've mentioned it here in my presentation today because I think it's important to know what does acceptance mean in this kind of trauma healing work. It's not about suppressing the emotions, it's about getting the support, if we don't already have it, to be able to digest and integrate our feelings. We're having this big event happen, we're going to have an emotional reaction, big or small, depending on who we are and how it's impacting us. And the function of working with these feelings can mean that acceptance leads us to create a new map of our environment. Often when grieving isn't possible for various reasons, we stay with our old map of our environment that is about before the diagnosis. I really don't want this world to not be mine anymore, so I'm going to try and act as if it's still there. And that can lead to a number of different stressors, additional stressors that come online because we end up overdoing things. We do more than we have energy for. We do a number of different things because we so desperately, of course, want to be healthy. And the new map can feel threatening and difficult or triggering, but what it can do is it can help us relate to our current surroundings, our current situation, adapt to it more organically, and then be able to actually support our bodies in a better way, in that we're able to care for them in a new, different way that we might have to learn. It might be a completely new way of treating the body. And then that can make some of those additional symptoms that might have come along go back or disappear a little bit. So that's essentially the why behind why should I approach my feelings around this devastating thing that has happened. What's the point of that? It is to create a new map, and it is to kind of update the software, if you will, to the current environment, to be able to respond to it as best as possible. Another bonus, if you will, another benefit of this is when we approach our feelings, when we process what we're going through, we'll be able to gather information from our feelings. And if we can do that, and that's essentially one of the main things we have feelings for, is to give us information about how do I feel about this thing that's going on. And if I can extract that information from my feelings, I can start to use that for next steps, figuring out how can I mitigate or potentially reduce my stress response. And not everybody's road towards this is going to look the same, but the key thing is basically to tailor this and try and find supports that works for you. And that's one of the hopes I have with this presentation today, is to inspire you and give you some more words to what is it that I'm looking for, and then who can I ask to support me with that, or who can help me find someone who can. So we've looked at pain and we've looked at trauma, and started to kind of sense the connections between them. But this next segment is essentially about reinforcing that and seeing what are the ways in which pain and trauma are connected and interact. Like I mentioned, this is how this happens for the brain and the nervous system, is that they travel in the same brain, the signals travel in the same nervous system. It is the information network in our body that conducts the signals both around pain and trauma. They're both attempts by evolution to increasing our chances for survival. And they can both be a way that the body stores information about danger, which then can lead us to other behaviors like avoiding things. And that can be good to a certain degree, but it can also be something that we do too much of. So we mentioned a little bit before about how receiving a diagnosis can have a traumatic potential. I also want to mention that having symptoms in itself, but especially when new symptoms come along, that is also events that we can look at through a trauma lens, so that we don't try and push ourselves or push back against it, but treat that also as something that is worthy of attention and care and support. To have a new symptom show up can be something that has a big impact on our mood and our view of ourselves and our future. Another aspect of pain that also I'm sure you are aware of, but I also would like to highlight here, is partially that it's ongoing for such a long time, but also that it's invisible. It's not like showing up at the emergency room with a big cast on your leg and then everyone can see what's going on. The invisibility of the condition makes it more at risk for other people's disbelief if they don't know about fibromyalgia, don't know about pain. They might struggle to wrap their heads around it and then make assumptions based on their own experiences or based on something they heard from someone else at some point. And that can lead to a lot of emotional labor in having to explain again and again, or having to prove or justify to other people that there is a symptom, there is a diagnosis. So that can also be something that is exhausting. Of course, it takes a lot of energy to have to do that repeatedly. And it can also create its own stress response, because being met with disbelief frequently, of course, is going to do something to how we trust other people and how we expect to be met when meeting a new person. We might get worried that they're also going to not believe or question our experience. Another term that I believe is important in this context to mention is complex grief, and that goes back to those emotions that I mentioned earlier. We often talk of the grieving process as mainly containing the emotion grief or sadness, But often, if we've had someone pass away we had a complex relationship with, or with an illness that we're experiencing, those other feelings of anger, shame, and so on are often present, and that makes the grieving process a bit more complex, and another approach or more support is often needed, more knowledge about what complex grief is in order to be able to approach and treat ourselves in the best way. So continuing to the next segment here, medical trauma when seeking help adds to the pain. That's often something that is this additional layer to our experience when, for example, the interaction with the healthcare provider or something else in that region is not going according to plan. And we're often at our most vulnerable when seeking support. So it can be really hard to not be impacted by that, which is what this segment is about, validating and acknowledging. So by adding this segment, I hope to provide a little bit of knowledge around this, and in doing that, power to be able to trust your reactions if you've gone through something like this, or if you're supporting someone who has, just by being able to put words to what happened, and then also be looking at what else is needed in order to repair. So some of the challenges, like we mentioned, receiving a life-altering diagnosis has its own traumatic potential. It can be difficult if it's a surprise to receive the diagnosis, or if we're feeling overwhelmed or in some other way out of balance, to communicate or access feelings, set boundaries with a healthcare provider if they are in charge of resources that you depend on, like the ability to refer you to a pain clinic, or the ability to connect you with some other resource for support. So that is something that often is, I find is important to be aware of, that it's hard to assert yourself in those situations, and it's understandable because of the power imbalance that often exists. So instead of, often people can experience shame after an interaction and wonder, why didn't I say something, or why did it happen this way? It is by design a very challenging situation to be in. It can also be challenging to interact with healthcare professionals who don't know a lot about long-term pain. It's getting better, but it still happens that people interact with people who don't know enough in order to be able to do the right interventions. And then that can also be something that we have a stress response in relation to. Another unfortunate aspect in looking for care is there can sometimes be a lack of access and resources in the healthcare system, and this can vary across provinces, vary across regions within provinces, but there is of course also something that is a stressor, and for that reason there are a number of online resources at the end of this presentation to help connect you to networks that are advocating for your needs, and to potentially help and see if you can access more resources if you're looking for more. Self-care and spaces to process emotions from an interaction can be really important afterwards. It can be one way of starting to develop and grow self-compassion, that this was a hard thing that I went through, and this is thinking about what do I need after that to help regulate and increase that sense of safety again, if possible. Finding professionals in communities that know and understand, where you don't have to explain and assume that there might be disbelief or a lot of questions coming, but instead knowing that other people know what's going on. And that leads us to this final segment of the presentation, access and support. So we'll have a look at a number of different treatments and looking at what makes them work. What they have in common are that they are aiming to regulate and encourage the parasympathetic nervous system activity to kick in. I don't know if this is a word that's familiar, but it's a really cool word to look up online, if you will, parasympathetic and sympathetic nervous system activity. You can find little drawings and maps over how the nervous system impacts different organs in different ways when these two patterns of activity are activated. And the parasympathetic nervous system is about that sense of safety again, and the sympathetic is about the stress response. So we want to help the body to also notice the things that are okay in the body at the same time as the pain is present. Not to distract from it, but to help the body to integrate and know that there's also things going on that are feeling a little bit more okay. So this can increase our sense of safety. Another word that is interesting to look up online that has to do with how we do treatments like this is interoception, and that's our ability to notice what's going on in the body. So just like a sense of taste, smell, vision, interoception is our brain's ability to notice what the body feels like on the inside. And many of the paths towards triggering the parasympathetic nervous system activity is something called polyvagal techniques. This is a fairly recent discovery about the vagus nerve, which is the longest or biggest nerve in the body that goes all the way from the brain down to the rest of the body. And the person who have built a theory around it and kind of starting explaining how to work with this vagal nerve is someone called Stephen Porges. And another good name to look up as well is Deb Dana. She has focused on turning Stephen Porges's theories into practice, actionable techniques. We'll be going into a trauma treatment a little bit more to give an overview of what it can be, but I'll also mention here movement. So if you're not already working with a physiotherapist or similar who's specializing in long-term pain, that can be a really important part of building that safety again in the body, because often we've learned that certain movements or certain ways of behaving are now triggering pain, and it can lead to the body predicting that it will hurt, and then it hurts more or it starts hurting sooner. So finding a way back into movement while movement gets to start to feel safe again is something that physiotherapists can help with. And accessing other types of care, other professionals, we'll get into that a little bit more soon. And also the sense of community, knowing that other people are also going through what I'm going through, and there is support to be had and there is understanding to be had, can also have that effect on us that we start to feel a bit more held, a little bit more safe, even if we are going through something very difficult. So looking at different types of resources, and this is going to be a little bit specific for Nova Scotia because that's the area that I'm familiar with. But if you're from other provinces, there will be different actors that you can try and access in your local community. There's one type of treatment that is specifically targeted towards long-term pain. It can be good to know about if you haven't heard of it already. It's called pain reprocessing therapy. And it's essentially using a lot of what I've talked about today and then putting it into a treatment program. If you haven't already, or if you're interested in pain clinic referral, talking to a doctor about that, and that can also be very different in different provinces, how long the wait time is for that. So that can leads us back to medical trauma there. If the wait time is very long, that can have been a stressful experience to ask for. But they do exist, and it is something we can discuss with a medical doctor to have a referral. If you're in Nova Scotia and can travel to Halifax, the one-to-one wellness clinic that I work with have started up a pain self-management program that for now is in person only. It might become virtual after a while, and that is a program that is created by a physiotherapist specialist in long-term pain, and it uses a lot of the information that we talked about today. Online could also be a good place to start looking. So we are here today thanks to Fibromyalgia Association of Canada, and for that reason I posted the website here. This can be a good portal for you to start accessing information and connections related to fibromyalgia. And the Power Over Pain portal is another good website that has courses and peer support available. If you're interested in using an app, this is one example, and it's called Curable, and it has a lot of information like we talked about the nervous system, but much more in detail, and then different types of exercises to help trigger the parasympathetic nervous system and work with polyvagal techniques as well. There are many books available. This is just one that is connected to the style of therapy that I do, and I've heard good things about it, so thought I would mention it here as well. It's called Unlearn Your Pain by Harold Schubiner. Another peer support network that would be good to look into if you're interested is the People in Pain Network. And this is their website. And there's also a national action network called Pain Canada. And they also have a really, really nice website. To go a little bit more into detail around what trauma-informed psychological treatment methods that could be of interest, I listed some of these here. Just so you can see what's available in your community or online in terms of practitioners if you are looking for trauma-informed psychological treatment. Somatic experiencing is SE abbreviated, a very, very good method that has a lot of the mind-body connection in focus, helping to treat trauma. And just so to be clear as well, these are not methods that are specifically for pain, but they are useful, I find, because of the link between trauma and pain and how they are interacting with each other. So that is why I just thought I would mention some of them here. Compassion focused therapy comes more from a CBT angle and works a lot with the ability to develop self-compassion and grieve and process some of those feelings that might be self-attack related, especially. There is a classic trauma treatment called EMDR that you might have heard of. It's called eye movement desensitization and reprocessing therapy. And that works a lot with the subconscious ways in which our brains work. So it's less focused on words than, for example, CFT and using words in treatment, but it's more similar to somatic experiencing, you're working more with the body, but more with specifically the eyes. Brain spotting is a fairly new method that has come out of EMDR, but it's less structured than EMDR, and a lot of people have appreciated that it has a bit more flexibility in how it's delivered. Also focuses on the mind-body connection and working with the eyes. And then there is the one I'm trained in, ICDP, Intensive Short-Term Dynamic Psychotherapy, which is a little bit of a Swiss Army knife in that it can work with many different conditions, but is especially focused on attachment trauma and the ways in which that can impact our ability to identify feelings as adults, process them, feel them, and then use them for interpersonal interactions and for learning about ourselves. So that can also be of use in this situation. Can also be, doesn't have to be attachment trauma from when we were younger, can also be from trauma that's happened in adulthood. If you're interested in a book in the kind of trauma-informed psychology field, there's one by Bessel van der Kolk, who is the author, if you will, of PTSD. He's one of the clinicians who coined the term post-traumatic stress disorder. And he has a book called The Body Keeps the Score. And through that, you can learn a lot about how trauma works in the body. There are also other professions that are important and can be of help when working with long-term pain. And in case you haven't interacted with them already, I've also listed them here. Like mentioned there a few slides ago, physiotherapists can be really helpful in recovering access to movement that feels safe, especially the physiotherapists that have experience with or have specific training in long-term pain. In terms of finding that new balance of what do I have energy for and how do I divide tasks or reconstruct, rethink tasks in my everyday life based on the symptoms that I'm having currently in order to help my body feel as safe as possible. Occupational therapists can be a gold mine in terms of working with something called pacing. Also feel free to look that up online if you want to find online resources if it's hard to access a occupational therapist. Another method that they can work with that also there's information on online is something called spoon theory. I recommend looking into those if you haven't already heard of them. There's also more in the kind of medical diet field if you want to discuss with your physician or a dietitian. There's also some research around anti-inflammatory diets, and that of course is a different field that is not within my scope, but it has some there's some research around that it can help reduce stress and inflammation, and through that can also be one way that we improve mental health and stress responses in the body. That was my presentation. Thank you all for your time. And I'll give it over to you, Trudy.
Thank you very much, Cecilia. That was really interesting and gave me a lot to think about. So I'm sure it's given everyone a lot to think about. Um, we are used to being diagnosed and left with all that trauma and not always dealt with properly. And I think a lot of people with fibromyalgia, I don't think they recognize that we have that's a traumatic event, and that how a doctor actually diagnoses you and talks to you once they've made that diagnosis can make the world of difference. So thank you for that. I think that's something we all need to hear, people with fibromyalgia. Does anyone have any questions they'd like to ask? Can you just put them in the chat if you do? Um, it's it doesn't take very long to have those stress reactions. Does it take a long time to learn how to deal with that and to come back to acceptance as we know it?
Absolutely. And one of the ways that it takes longer is just the way the mechanisms in the nervous system. So to start having a stress reaction, because it's been so vital for survival, happens within milliseconds. Like it just shoots up real fast. And that's, of course, we have survived because we responded like that to tigers and so on. And the parts that humans in ancient history who didn't respond that fast, they were eaten or eliminated from the gene pool. So we are good at being anxious for a reason. We are good at getting stressed. And then the mechanisms in the nervous system that help us return to a sense of calm work much slower. So it literally isn't possible to go stressed and then not stressed as fast as you went up. It's not how the body works. So that can be one way of adding self-compassion to the mix, is to know that about bodies and then go, okay, I'm going to need some time now in order to come back down again. There will need to be a few things in place around me, or need these things in order to settle in. And then if it happens frequently, we're also maybe going to get a baseline that keeps getting higher, where it gets triggered more and more easily over time.
Thank you. Something that I find that I do myself, and my daughter has fibromyalgia, I find she does as well, is on a good day, we think that we can go run a marathon, right? And then and you do feel good and you do things, and then the next day you don't, and you think, and some people find that discouraging and think, so especially when the researchers show that exercise is such a good treatment for helping with symptoms of fibromyalgia, and you try to do that exercise and then you go into a bit of a flare, so you can hardly move off the couch for 3 days, it kind of is discouraging. Can you explain that phenomena?
Absolutely. It's something I learned in the pain clinic in Sweden, and that is, it's so central to understanding the body and the nervous system when it comes to this, because what you describe is really common. And the pacing that occupational therapists work with is essentially where it's at, and the physiotherapists can also be involved in this, because the new limit for what we can do is lower than previously. So on a good day, we want to make sure we stop before we go past that limit. And that's where the psychologist comes in, because that is often frustrating. That is often grief-inducing. Like I feel like I can do this, or I can do this today, but I have to stop here. That is not fun. But what I can do, if we learn about the need or the function of doing that, is we can stay there and then not have as much of a crash, and then the capacity can sometimes increase over time. But it is really common that we try and do everything in one day. So It's
Yes, it is.
Yes, it is. So it's preventative care, if you will.
Mhm.
We need care on the value that comes afterwards, but it is about trying and find different ways to not go as high on that first day, which of course is really hard when bills need to be paid, the living room looks like a mess, and all those things. So it can really be helpful to either have community members to talk and learn from their tips and tricks, or finding a healthcare professional to kind of work out that frustration with and figure out a plan that can feel a little bit less rocky.
Well, the good news about that is that if you only go so far so that you don't crash the next day, gradually that amount you can do does increase. So
Yeah,
that's the good news about that.
yeah.
So Terry asked if there are any workbooks to help a person work on the past trauma that can help with changing how we look at pain.
So there are a number of things. I would encourage you to go on those community websites for peer support, for seeing specific pain information. There is a number of trauma books. I saw a short list recently about understanding trauma, but I don't have the link here. But another author that is really interesting in this field is Gabor Mate, Gabormate. And then there's tons of other things. There was one on Oprah recently called "What Happened to You" by another author that I can't remember. So there's many things out there.
What was that last one? What happened to you?
What happened to you? That one was specifically about intergenerational trauma. So
Mm.
if, for example, grandparent was in a world war, or it doesn't have to be something that big. It can be that they had an abusive parent and then they learned from that and pass, without meaning to, pass it down throughout generations. So that one, what happened to you, was specifically about intergenerational trauma.
Thank you. So thank you, Cecilia. This has been really great, and I really
Thank you.
appreciate it. So on behalf of Fibromyalgia Association Canada, I would like to thank you for coming today, and maybe
Thank
we
you.
can talk again in the future.
I hope so. Thank you so much for inviting me, and I hope that this has been of benefit to some of you.